as a moderator and a speaker in the section, you get to channel your inner Austin Powers. So if you will allow myself to introduce myself, I will be talking about therapeutic options for Richter syndrome. I'm at Cornell. So here's the agenda for this talk. We'll talk about some risk stratification systems that are currently in place for both diffuse large B-cell lymphoma and Hodgkin lymphoma transformation variants, which are the two most common as we've learned. The CIT approaches that are currently employed and kind of the standard of care for upfront induction treatment for Richter syndrome. We'll look at DLBCL as well as Hodgkin's. There's been some recent publications, small series, trying to assess optimal treatment options for the Hodgkin variants. We'll go over that. We'll talk a little bit about the transformation in the era of novel agents, the risks of transformation on these drugs, as well as the effectiveness of these drugs. And then the kind of going towards the future immunotherapeutic approaches as well as novel agent approaches and potential new models that we might be able to utilize to identify synergistic combinations. So there are a couple risk stratification systems that are currently being used for diffuse large B-cell lymphoma specifically, and really what's important out of these patients or out of these systems are really the performance status, the P53 status, the response to the induction therapy. There's a few lab parameters that you can look at to calculate these scores, and then clonality, which is always important to assess when you have a patient who transforms. And so then what scoring systems can we use? There's two that are pretty well validated, seemingly. MD Anderson in 2006 published their 5-point Richter score, kind of termed this idea of a Richter score. And then David Rossi in 2011 reassessed and established, the Rossi Richter score with his collaborators. And so these are the two things that you can use at diagnosis when somebody's in your clinic to assess how are they going to do potentially long-term as they embark on a treatment course. And so here's just some of the data from the MD Anderson group published in 2006. They looked at 130 patients treated at their center that were biopsy proven, either core or FNAs or excisional lymph node biopsy, but biopsy proven, not just clinically proven, and had 130 patients that they looked at, and some were before rituximab, some didn't get rituximab, some were just getting straight chemotherapy, and some immunotherapy alone. And what's important is when you look at the response rates and CR rates, they're not very good. So CR rates are low, less than, in this 10 to 15% range. The overall response rates are in this, 30 to 50% range. Rituximab may add a little bit. But ultimately, when you look at that compared to a de novo diffuse large B-cell lymphoma, these are drastically different and much worse outcomes than we've seen. For a lot of reasons that we've heard about. The biology is different, and these are chemo-refractory lymphomas. And here's the survival curve of these patients. You can see a median survival less than a year. A lot of the reported literature is anywhere from 8 to 12 months, basically, median. And that's even using hyper-CVAD, EPOC, intensified regimens. Have done little to really improve on this median survival of this 8 to 12 months. And when it shook out, the multivariable analysis basically identified of these 130 patients, these 5 parameters that you can use and calculate upon a diagnosis of a patient sitting in front of you. And it's simple, it's easy to use. These are common things that are done, and you can identify a patient as low, intermediate, or high risk based on how many points you give them. And it bases on performance status, your LDH being abnormal, your platelet count at time of induction, tumor size, and prior therapies. And when you look at the data, it shows that basically 2 or less kind of overlap, but maybe at the tail there may have a little bit of a difference, but identifies people in low, intermediate risk categories with different overall survival. This is overall survival, with the highest risk patients with 4 to 5 of those risk factors having median survivals less than 6 months. And so this is something that can be helpful when you are educating a patient and or family about options and what to expect potentially, and why getting a diagnosis can be also helpful, because there's nothing left to wonder of what you're actually dealing with. And so in 2011, this was kind of re-examined with David Rossi and his group in Italy, and for the first time, we've seen this curve a lot. I won't belabor it too much, but for the first time, really kind of had this appreciation of the difference, that there are different transformations, and that Richter's transformation probably should be restricted to a true clonally related transformation, just because the outcomes are so much different, and that unrelated transformation may behave much more like a de novo diffuse large B-cell lymphoma and potentially have a long-term curve and either be cured with upfront chemoimmunotherapy. But this is one of the first studies kind of really understanding this difference between the two. And let me remind you that 80% of transformations in a CLL patient are typically clonally related. So the unrelated transformations are relatively rare, and you don't typically see them. And if you have high-risk CLL, it's almost guaranteed that it is probably going to be clonally related. So keep that in mind. The other appreciation here was incorporating some molecular factors that had not been done previously, because we weren't really utilizing those or understood the impact of those. But P53 disruption, this isn't just deletion, this is disruption, deletion and or mutation in the allele of P53 gene has prognostic significance for these patients with Richter's transformations. This is a group of 86 patients, biopsy proven at their centers there. And again, the appreciation of this. So when it boiled down to the multivariable analysis, the lab parameters kind of fell out, and really it came down to performance status, whether or not you responded to your induction treatment, and whether or not you're P53 disrupted. The big difference between these two scoring systems and models is the first one you can utilize with the patient sitting in front of you upon a diagnosis. This one, it's retrospect. You actually have to know what their response is, and so you kind of only know that a couple cycles in. If they were responding, will they be in this group or not? But upon getting a remission, if they do, you can use this model. So you'll have to keep that in mind. But what this showed is that it does nicely at breaking patients into 3 different groups: low, intermediate, and high-risk groups, with the high-risk patients, again, having very poor median survivals right around that year-long, about 12-month median survival, whereas if you're intermediate risk or high risk, you can potentially have long-term remissions. Obviously, the people who get into CRs typically go on to allo, so this is always a complicating factor in a lot of these. As you see these long-tail patients, they're likely transplanted and were transplanted in a CR, and so keep that in mind. But there are patients that can have long-term remissions and potential cure with aggressive treatment if they do respond. And you can see the stratification here is that you're low risk if you have a good performance status, you have no P53 disruption, and you get into a CR. Whereas if you are a poor performance status patient, it doesn't matter what anything else is going on, you are high risk. If you are kind of a bed-bound patient in a wheelchair, unable to interact, you are by definition high risk regardless of any other factors, and you are considered intermediate risk if, one, you don't get into a CR, or if you are P53 disrupted. And so why the power of this model is that they then went and examined their 86 patients and gave them the MD Anderson Richter score, and their model essentially recategorized a lot of patients into intermediate risk. So you can see half of, almost 60% of patients that were 0 to 1 point actually fell into the intermediate risk category, incorporating genomic data and response rates. And so ultimately it performed a little bit better in terms of predicting how patients might do, and using this kind of after-the-fact model might actually help you predict and prognosticate and manage a patient potentially going into that next line of treatment, whatever it might be. So talking about Hodgkin's, there are a few studies that have been done. Now, mind you, this is pretty rare. We've seen of the transformations of patients who transform, about 10% of CLL patients might transform in a 10-year span. Of those, 90% of them or more are Richter, DLBCL Richters. so 10% or less are Hodgkin. So you're taking a very small percentage of patients who transform, and then an even smaller percentage of patients who transform to a Hodgkin variant. So needless to say, the studies out there with large numbers of patients are lacking, and to do these multivariable analysis, you need large numbers of patients, so we don't really have a lot of predictors for Hodgkin's. But one of the largest series was recently published last year by the Italian groups, and they reported on 33 patients who had a Hodgkin transformation out of 4,680 CLL patients at these 10 Italian centers. When they looked at how they were treated, 66% of them got ABVD, so pretty good standard of care therapy for Hodgkin's. The CR rate was 66%, and that's comparable to what we see kind of with ABVD and de novo Hodgkin lymphomas. And really the only thing that shook out in this multivariable analysis was a complete response to treatment. That predicted patients who were going to do well long term, sort of like what we know with patients with Hodgkin's lymphoma. There were some other things. So this is the survival curve. You can see while these patients actually do much better than a patient with a diffuse large B-cell lymphoma, Richter's, but that they still do worse than what you might see with a de novo Hodgkin lymphoma, with median survivals in this 3 to 4 year range, whereas we know the curability, obviously, of even stage 4, advanced stage 3 and 4 disease of Hodgkin's, pushing out, 5 year, 7 years PFSs, disease-free survivals of 70%. So biologically, it is a different disease. We don't quite know the differences between the clonally related, as we saw less than half of the Hodgkin transformations are clonally related. We don't quite understand that because, and we don't quite understand the molecular predictors because Hodgkin cells and the massive inflammatory cells that you see on a transformation are difficult to dissect out and do molecular studies on, and so we don't really have a good handle on that, and obviously that will take a collaborative effort and or a lot of hard work, basically. So one thing that also came out is if you have higher IPS, you do worse than patients who have a lower IPS score for their Hodgkin's. And this is something that's known. It's not too surprising, but you can, you might be able to help guide expectations based on the IPS score as well. And then here's the striking data if you had a CR, and you can see this is, we're really pushing out far here. So obviously getting into having responsive disease bodes very well if you have a Hodgkin transformation. The other issue here is obviously a lot of this study was done in the era before brentuximab. Now that brentuximab is an FDA-approved frontline treatment option for patients with Hodgkin's, how will that affect this? I think that remains unknown. Obviously, that's going to be a collaborative effort to assess a series of patients treated with brentuximab AVD. I know in our clinic we've done it twice. We've had good success. Would they have had the same success with ABVD? It's unknown, but we are following these patients and looking to collaborate with people to try to understand the effect of brentuximab in this population. So just moving on, is there a standard of care for upfront transformation? Chemoimmunotherapy has been the mainstay. Richter's syndrome-specific cohorts have successfully been studied. And cross-study comparisons, because these are all typically phase 2, none of them are phase 3, none of them are typically randomizing you because this is a rare population. They're hard to get on a study. Patients are very sick. They don't necessarily meet eligibility criteria frequently. But cross-study comparisons really suggest no ideal regimen. And limited prospective data is available currently of incorporating novel agents into upfront induction regimens. And so I've been trying to collate a table, and fortunately, Dr. Rossi, and my table I thought, did a pretty good job. Unfortunately, or not, fortunately, Dr. Rossi did a review, and his table is much more comprehensive as he does several of these. So this summarized a lot of the available data out there. But again, I want to just highlight, not necessarily the busy slide here, But just looking at the DLBCL cohorts, small numbers of patients, but restricted to Richter's patients. And again, the overall response rates are not great, and typically the CR rates are in this 15 to 20% range, which is much different, obviously, than what we expect. And then most importantly, the PFS and the OS is still not good. Despite EPOCH, despite adding new generation anti-CD20 antibodies like ofatumumab, and really nothing's kind of beaten our chop, frankly, in terms of PFS or overall survival. But all of these are reasonable options to consider. I think the vast majority of patients are being treated with CHOP-based treatment, EPOCH-based treatment, and we have yet to prove that one is necessarily any better than the other. When you look at Hodgkin's, obviously these patients do better with this median survival of a little over 3 to 4 years, and you can see most of these studies were pre-brentuximab, so not many patients were being treated with brentuximab up front. So how will that impact it? It remains unclear. So what about transformation in the era of novel agents? Do novel agents increase transformation rates? Is there a time frame to suspect transformation when you start a patient out? Are novel agents even effective for this disease? And are there any currently available Richter's models? So this is where the review got really much more extensive than my group of studies. But what's important here is that it's a lot of clinical trials. These are CLL studies. This is assessing the transformation rates on the studies, not necessarily treatment for the Richters, but the transformation rates. And you can see the numbers of patients that are being transformed, and then how that correlates into the relative prevalence of the population. And these are chemotherapy studies. These are ibrutinib randomized phase 3 studies going on, and so on and so forth. And what you can see, the transformation rate is typically in this 5 to 10% range as we start to get into more advanced disease, patients treated on venetoclax, and just it's a thing of something to just point out is that these studies have short durations of follow-up sometimes. Many are retrospective. Additionally, a lot of these studies don't require PET scans and things like that to even enter onto them. And so sometimes Richters may even been pre-existing, which is always a criticism of trying to understand what is the transformation rate on these studies. Was it pre-existing? Was it not? So just keep that in mind. But you can see that some of these studies in relapsed refractory 17P venetoclax patients, the transformation rate is not low. And so, a quarter of these patients were transforming as their, progression. And sometimes it's not even reported in a lot of studies, so you really have to dig into the supplemental indexes and things like that to even find some of this information. So kudos to them, and this is a nice table to be able to build on as we move forward. But one other thing to point out is that in the phase 3 studies, there has not been increased Richters in the novel agent arms. And so it doesn't appear that by being on a novel agent, you are at increased risk of a transformation, is that it seems they are relatively equivalent to those control arms. So when does transformation occur? We've seen this study, but typically it peaks at this 18 to 2-year mark, and then it starts to plateau. And so you need to start to suspect it in that first year and a half or so. Of a patient who is progressing with lymphadenopathy, that's high risk, night sweats, LDH is rising. These are the patients that are going to transform. And then all these other risk factors, especially if they have Notch or they have a MYC alteration, these are the patients you got to watch out for. And obviously, having PET scans and things like that before you even initiate treatment is always, in a high-risk patient, is always a thoughtful thing to do to really rule it out before you embark on a single-agent novel therapy. So there is a lot of fanfare a couple years ago for immunotherapy and PD-1s. PD-1s haven't had much success in lymphomas in general, outside of like Hodgkin's and a few other studies that may have shown some data with follicular lymphoma, but a lot of other studies haven't shown a lot of activity. But the Mayo Clinic demonstrated some activity for pembrolizumab, and there was a lot of fanfare because the CR rates were relatively the response rates were high, and patients were doing okay, and this was a single-agent pembro study in a mixed population of, again, very small numbers of patients. And then the Ohio State group actually reported their single center use on their 10 patients and kind of showed a little less robust data. So I think it's a little bit unclear really how well effective PD-1 antibody therapy as a monotherapy is for Richter's, but it's a decent option. There are some patients that do long-term, as you can see. There are some patients that may respond. This is months, obviously, here, but there were some long-term responders in the Mayo group. But obviously, most of these patients, so this is different than the previous report, that the median PFS was basically in this month-and-a-half range. So they got a couple doses in and were progressing. So I think as a monotherapy, I don't know if it's there. There is some data coming out that PD-1 expression might predict somebody who might respond. Again, small numbers. This needs to continue to be examined. So what about novel agents for Richter's? So basically, there's been a few studies that have reported Richter's included in the clinical trials that were phase 2, and this is taking those 8 patients out, let's say for selinexor. Response rates were there, no CRs, obviously. They didn't report in this subgroup. Again, acalabrutinib has had a publication in a Richter-specific cohort showing some CRs, showing a decent response rate as a monotherapy, but again, this duration of response was in months, and so it's not the answer necessarily for Richter's as a monotherapy. Ibrutinib, there's case reports out there. Many of these patients who respond are ibrutinib naive. That's going to be becoming a much rarer situation. And then the Pembro study with 10% CR rates, this response rate of 50%. When you add ibrutinib, MD Anderson has shown with nivolumab some good response rates. There is some immunomodulatory activity of ibrutinib that might improve that. And venetoclax, again, some response rates, but small numbers. And then for CAR T cells, the Seattle report did have 5 patients that were transformed when they went on and received their product, and did show a 60% response rate, and what is that? 2 patients out of 5 got a complete remission and may have had long-term remission. So there's promise there potentially. Again, very small numbers. This is a field that needs to kind of come together basically to figure this out a little bit. So here's a sampling of studies of kind of what is happening now, and obviously single agent treatment, as you've seen, is probably not an answer to handle a disease as aggressive, as complex, as refractory as Richter's syndrome. And so incorporating these new drugs into induction regimens is now being done. Dana-Farber has a venetoclax R-EPOCH for RS only. Ibrutinib, obinutuzumab, CHOP, that's being done by Dr. Barrientos. There is out of at San Diego by Dr. Kipps, obinutuzumab and Revlimid with high-dose methylpred. I think MD Anderson has a blinatumomab bispecific for RS specific. This is from clinicaltrials.gov. I believe it's enrolling. We have a study that was enrolling selinexor plus rice for patients with a Richter's cohort. The Pembro is being re-examined with U2. And then obviously the nivolumab and acalabrutinib, and these are accepting Richter's patients as well. Acalabrutinib and visartusertib is enrolling some Richter's patients. So how can we do better? We'll just finish up quickly here. Develop ideal models, understand better transformation in the era of novel agents, and target the specific underlying biology. So one approach that we're taking at Cornell, I have aggressive biopsy to really rule this out, and we've been able to make a few PDXs of these patients. Samples, and they are now propagating and now are being used as drug development, testing models as well as understanding the biology. So this is a report of 2 subjects that we were able to develop a PDX from. You can see their treatment course, their CLL course. Obviously, upon treatment and diagnosis of Richter's, they had short lifespans, but were treated with several novel agents. You can see different growth kinetics of the PDX cells, and when you look at immunohistochemistry, they are very identical to the primary tumor, which is on top, and these are passes in the mouse that remain nearly identical to that primary sample. And this is done with our collaborators in Italy, Tiziana Vaisitti as well as Silvia Diaglio. And then when you look at these, we've genomically characterized them multiple passages out, and for the most part, the clonal architecture remains relatively stable. This is the primary tumor, and here are multiple passages of the PDX in mice. And so each dot is a different passage, and you can see relative genomic architecture stability that replicates what was in the primary tumor. There is some clonal drifts and clonal changes that occur in the mouse. You can see this PDX was a little bit different, but when you look at the pathways, they're all relatively stable and not much is changing, and then the transcriptome is 85% correlating to the primary tumor. And so these are great models to use. And what they found is that there's constitutive activation of BCR pathway, NF-kappa B, Notch as well. Some are activating in MYC, others are not. And so each one is actually a little bit different. Will transformations without therapy be different than those on therapy, those on novel therapy? That remains to be seen as we develop more of these models. And as a proof in principle, we've tested molecules. This is IT901 is a NF-kappa B inhibitor, and what you can see here in a mouse, in a flank tumor, that by treatment with the drug, we can get some shrinkage of the Richter's tumor. We've now developed these models to actually be injectable, tail vein. Some of them are taking, and so now we can assess systemic disease, not just in the flank of the animal, which allows survival curves and really multiple dosing of the animal. And so it's an exciting model. As we develop more of these, we'll characterize more of these as we move forward. So in summary, and I'll just finish up here, I'm a little over time, scoring systems are currently available that you can use and look up to risk stratify for your patient. Hodgkin variant Richter syndrome predictors are lacking, and the impact of A plus AVD on outcomes is still unknown. Historically, CIT regimens are associated with poor response rates and overall survival. Novel agents do not appear to be associated with increased rates of Richter's transformation in the randomized studies. And transformation, usually a common event on novel agents in relapse refractory settings, and a commonly early event. And single agent therapy is not going to be the answer. And using these PDXs and other mouse models that are currently out there, there is potential to identify the synergistic combinations exploiting the unique biology of this disease. And with that, here are our collaborators, and thank you for your time.